I'm Kunal Kabanda, consultant at King's College Hospital, and I'm part of the Dialysis Society. This is part of our series of webinars, which we have every 2 months. Our webinars are made possible by industry sponsorship, so I'd like to thank Stanley Pharma today. We've got a education committee as part of our society. It's made up of myself, Natalie Borman, who'll be joining us shortly, Suzanne Forbes from BART, and now Helen Hurst from Salford. So today we've got 2 brilliant talks from Prof. Yaqub and Beverly Bain-Cobb. So without further ado, I'm going to hand over to Prof. Yaqub, who is a nephrologist at the Royal London with over 450 publications, and he's going to be speaking about acidosis and CKD progression. So over to you.
Thank you very much. I hope you can see my slides. If somebody gives me a thumb up, Kunal, I will just...
Yeah, we can see those. Thank you.
Okay, thank you very much for inviting me. I'll just take you back to my medical student days. Believe it or not, I was a medical student once. One day I was contacted by my professor of urology stroke nephrology so many years ago that I have to review this article in the Department Journal Club, which was recently published in American Physiological Society, which was 1981. He told me that this article will be presented in front of the visiting faculty, foreign faculty, no pressure, and we don't want you to let us down. And this paper has been selected especially for you because it will be a game changer in the field of nephrology. So I'll just quickly take you through this. It was really a game changer, what it transpired afterwards. But it was a very simple paper, came from Barry Brunner's lab in Harvard, which was to give some rationality to the treatment of the time at that time was low protein diets, which was supposed to improve symptoms in patients who could not get dialysis, and also was supposed to prolong their life. We didn't know how this low protein diet worked. And in order to study this, they used a model called remnant model of CKD, which I'll briefly describe you how it is a bread and butter model in my lab. How it works is that you take a rat, take 1 kidney out. A week later, you do a stage 2 procedure and take 5/6 of the second kidney out, which leaves basically 10% of the nephrons, total nephron component in the rat. Those nephrons over the time undergo hypertrophy, run a bit, and then they start going glomerulosclerosis. And it was considered that it happens because of hyperfiltration in the remaining kidney, and possibly low protein diet reduces this hyperfiltration and reduces the barotrauma. But there was no direct proof of that, and this paper gave the direct evidence that that is really the case. Just quickly going over, group 1 was a sham operated animals which did not have any nephrectomy. They just opened the tummy and then close it up. Group 2 was what they went under 5/6 nephrectomy after unilateral nephrectomy, and they were fed normal diet. Group 3 included 7 rats that went again 5/6 nephrectomy and were fed low protein diet. Just to tell you what normal diet of a rat is, in a normal chow of a rat, the protein intake is 0.75 gram per kilogram body weight, which is equivalent to our normal protein intake should be. And group 3 were put on a low protein diet, which equated to 0.2 gram per kilogram body weight. So remember, 0.75 was reduced to 0.2 gram per kilogram body weight. By doing so, the main novel thing about this was that there was a micropuncture technique which would measure the glomerular capillary pressure and would drive the single nephron GFR. By doing those fanciful micropuncture technique, they were able to demonstrate that when you did 5/6 nephrectomy on normal protein diet, you had an increased single nephron GFR compared to the normal rat. And the capillary pressure was higher, but this was all normalized to the baseline normal control level if you were to keep these animals low protein diet. At that time, it was the first objective evidence that you do get increased capillary pressure in the remaining glomes, and low protein diet possibly reduces that capillary pressure, and by that it will protect the remaining nephrons. So it gave rationality to low protein diet, which was the vogue of the time and the treatment of the time at that stage. The people who were the foreign faculty when I presented this paper were some serious players of the time who were proposing low protein diet. So having said this, I had to criticize this paper, but it was a superb paper. It was a game changer, as everybody thought. But one would like to give some criticism in front of all these foreign dignitaries. And my criticism at that time was that I think 0.2 gram protein diet would not be possible in human beings. Second thing is that they did not look at a protein balance in this study, whether the animals were getting protein malnourished. They did not look at any other things which go with protein, which is phosphates and sulfates. And this is where I would come in, that low phosphate and low sulfate will also reduce the acid burden of what you eat as a protein. But overall, very good paper, got a lot of congratulations and pat on my back, and that's where it left. But what happened subsequently was to change the field of medicine, of nephrology. There were a lot of randomized controlled trials done of low protein diet with normal protein diet in patients with chronic kidney disease. But most of those studies which were done initially were using creatinine-based measurement to look at the kidney function. We needed a definitive study, which was published again from America, mainly in 1994, which was the effect of dietary protein restriction and blood pressure control on the progression of chronic kidney disease. This was a landmark study published in New England Journal of Medicine and was basically essentially negative, because they had used low protein as 0.6 gram per kilogram body weight, as well as in a small group, they also used 0.4 gram per kilogram body weight. But remember, the experiment had shown that you have to reduce protein to 0.2 gram. That was not feasible because it was known by then that that level of protein will cause protein malnourishment. This study was negative. That put the end of protein restriction in CKD, but it gave us a classification through MDRD equation, which was derived from this study, because this study was the only study which used measured GFR, and from those parameters we derived this equation, which changed, I think, the clinical field of nephrology, when we got the handle of staging of chronic kidney disease, and that led us to believe that at the moment on this planet, there are over 850 million people with CKD of some stage living today. So that brought this nephrology specialty when I was a trainee, which was a marginal and fringe specialty, to the center stage with so many people needing nephrology input. And that led to many more appointments as nephrologists. So it has done a huge favor to a specialty of nephrology, and we have got so many nephrologists today. So directly or indirectly, that study, which was published from Barry Brenner's lab, did change the landscape of nephrology. From the same lab, Roberto Zatz, who is a friend of mine now, who works in Sao Paulo, published a paper in JCI in 1986, where he made the animals diabetic, and they were not renal failure. That diabetic caused increased single nephron GFR, and also increased the pressure within the capillaries. They were normal renal function rats. But he used enalapril, and when he gave enalapril, which is an ACE inhibitor, he normalized the glomerular capillary pressure. And that was also reflected in reduction of proteinuria. So this is where the concept came that ACE inhibitors, on top of their antihypertensive properties, have got a specific nephroprotection effect by causing low blood pressure in the capillary circulation, which is then associated with low proteinuria. So that is the antiproteinuric concept which come from ACE inhibitors. However, it was interesting to me. I wrote letters to Robert Dosat and said that you didn't use any other antihypertensive in this model, which would have given that ACE inhibitors are what they are doing at capillary level, or is it the blood pressure lowering property with systemic low blood pressure, which is causing the effect at the glomerular capillary level? That's a long story. I won't go into the exchanges I had with Robert Dosat, but subsequently, when I got a chance of doing micropuncture techniques myself in 1995-96, I was able to demonstrate that even beta blockers would give the same effect in this model as well as in a remnant kidney model. So it was possibly mostly due to the systemic blood pressure lowering effect of ACE, and a lesser extent to the glomerular capillary. Why I'm talking about all this thing, which is nothing to do with acidosis? Yes, it is to do with acidosis because ACE inhibitors, even in these animals, caused hyperkalemia, and hyperkalemia causes acidosis. So for me, it was interesting that acidosis, in the presence of acidosis, ACE inhibitors are still showing some meaningful beneficial effect. So that got to be borne in mind as I progress with my slides. Here, we didn't have to wait that long as we had to wait with the previous observation from Barry Brenner's lab, that whether ACE inhibitors do have the benefit or not. Within a year, a paper appeared in New England Journal of Medicine from Japan, where they looked at 10 patients with diabetes and uremia and were able to show that captopril, which was the ACE inhibitor in use at that time, reduced the proteinuria, and they thought that this is directly due to intrarenal lowering of intrarenal hypertension rather than systemic hypertension. There were 10 patients, no controls, and they showed that how easy it was in 1985 to get a paper in New England Journal of Medicine. I would say that it would be possibly not accepted in modern time in that journal. Then a flurry of RCTs happened. Obviously, when you use ACE inhibitors against placebo, there was a definite profound effect of renal protection. But when these meta-analyses got hold of studies where you use ACE inhibitors against another antihypertensive, whether it be calcium channel blockers or beta blockers or whatever, this specific effect, so-called specific renoprotective effect, was not seen. And that is the study which shows that it is a meta-analysis published in no less a journal than Lancet, that ACE inhibitors possibly are working through lowering blood pressure rather than any specific glomerular effect. The same thing was now emerging in stable coronary artery disease patients, that if you were to use ACE inhibitors and you use it against placebo, definitely you saw cardiovascular protection as well. But when you use it against another competitor, which is any other antihypertensive, and if the blood pressure was the same in the two groups, that beneficial effect, which was allegedly due to RAS inhibition, tended to disappear, and there was no benefit seen over blood pressure control, a specific cardiovascular protection. This is the scenario we had. Just to reiterate even more, that we need to, and this is for the juniors juniors who are obviously listening to this, hopefully, that whenever you do a renal a randomized controlled trial or reviewing it, try to calculate fragility index. It is a mechanism by which you see the robustness of the data which is presented in randomized controlled trial, which I've been doing it for the last 30 years for myself, to see how robust that data is, and I can assess it myself. This index tells us that how many events have to become negative for that significance to disappear. This gives you that number. And as you can see, that when the ACE inhibitors were used in randomized controlled trials, in CKD population, you needed 5.5 events to become negative for the significance of dot paper disappearing. That is including 80,000 patients. So this, even if it was beneficial, I think that this study showed that the overarching benefit of ACE inhibitors in renal protections, if anything, is minimal or moderate at best, rather than a very potent beneficial effect. It has been proven now to me, having been a cynic of ACE inhibitors for the last 35 years, that, and this was a study done from our country, UK, STOP ACE trial, where they took patients with stage 4 and 5 patients, and they randomized them into stopping ACE versus replacing it with somebody else or some other agent versus continuing with ACE inhibitors. Very nicely studied. If ACE inhibitors were that good, then stopping ACE inhibitors would have caused more harm to the patients. In this study, as it went on to show that whether you stop it and replace it with some other agent or continue with it, there was no benefit whatsoever, no harm to the patient whatsoever, implying that at least in stage 4 and 5, you could quite safely replace ACE inhibitors if you don't want to continue with it, with an alternative antihypertensive, if you were worried about potassiums or premature decline of GFR needing dialysis. That brings me to my pet subject, which is acidosis. ACE inhibitors do cause acidosis, and protein restriction improves acidosis. So I've been interested in acidosis for a long period of time, and I've been aware both from my preclinical data as well as human data that acidosis causes anorexia. It inhibits albumin synthesis. It promotes protein degradation. It causes oxidation of branched amino acids, most of which are essential amino acids. And there was a possibility that in end-stage renal disease, correction of acidosis improved nutritional status. Some very small RCTs were done in patients on dialysis that correction of acidosis improved end-stage renal disease. However, most of those studies were done at the time when we used to use acetate-based dialysate, which used to cause acidosis in the early part of dialysis. So that may be just because of that. Then paper came from JCI in 1985 by Carl Nath, who was a registrar at the time when I was a registrar in UK, but he couldn't hack it here. I mean, not hack it, he thought that he possibly will go to America, and he went to America and started working with Tom Hostetter. Tom Hostetter was the first author of a low-protein diet in the remnant kidney model. And they looked at it in the same remnant kidney model that experimental CRF is associated with increased tubular ammonia production, because ammonia production will happen because of acidosis, and ammonia did activate complement 3 alternative pathway, and bicarbonate supplementation in the same remnant kidney model was able to stop the tubular interstitial fibrosis, which is the hallmark of progressive kidney disease. And this is the black and white pictures of 1985 from that JCI paper. If you believe it or not, the right-hand column, which is where my arrow is, were the rats who were treated with bicarbonate. and that you can see that the tubules are back to back as compared to here, and the staining for complement fragments was much milder in bicarbonate-treated animals as compared to those who were not treated with bicarbonate. So there was now this solid evidence that acidosis may be playing a role in tubular interstitial fibrosis, which we all know is the strongest predictor of progressive kidney disease. Acidosis and progression, when that paper was published, people started looking at it more closely. Some papers were published where they gave acid to the animal and were not able to show chronic renal injury in the rat. But they were not, remember, they just made them acidosis with normal renal function, and there was no effect of that intervention in these rats. There were some papers emerging that metabolic acidosis induced endothelin and promoted progression of renal failure in rats. And there was some evidence that tubular peptide hypermetabolism during progressive kidney disease leads to ammonia production and may lead to progression of renal failure by causing tubular interstitial fibrosis. But we needed an evidence. So when I became a consultant, I had this thing in my mind. I just observed people with stage 4 and 5 chronic kidney disease and just looked at their acidosis versus non-acidosis. And at that time, there were no guideline whether to treat or not. So I just observed them over a period of 2 years and found that those people who were non-acidotic were declining GFR at a very lower level, which is like about 1 mil a year as compared to 3 mils in those who were acidotic. By doing all the multi-regression analysis, I was convinced that acidosis here is playing a role in the progression. So obviously the next stage would have been that you have got a hypothesis that acidosis causes progression. Observational studies were telling me that, which was my own observational studies, and basic science was telling me that there may be some evidence that acidosis does play a role in progression of chronic kidney disease. That led to the study, which I'm going to now talk in a little bit detail, but I'll just zoom through the results. It's all published, and it's a very long study. It was the first study of its kind where we took a patient with acidosis, stage 4 and 5, and randomized them into bicarbonate and standard care versus standard care. There were more than 120 odd patients who were randomized, and acidosis was defined based on sodium bicarbonate level of less than 21 and greater than 16. We didn't get the ethics for leaving the bicarbonate lower than 16, so we chose this range of patients who would have this range of acidosis, and we will then randomize them into the two arms. Exclusion criteria were what would be usual for any study of this kind, which are not to be gone, which is sepsis, uncontrolled hypertension, fluid overload, congestive heart failure, steroid therapy, morbid obesity, and cognitive impairment. These were the measurements, which I will not go into, but I'll tell you as the results appear. So they were all clinical based, and we didn't have the money to do measured GFR. So we used both serum and urine creatinine-based kidney function tests, which we thought would be useful if we are also looking at nutritional status of these patients. By the way, we also looked at eGFR, and the results were identical. We had 184 patients, 134 patients got randomized, 67 in no bicarb and 67 in bicarb group, and we gave around about 1 to 3 grams based on the bicarbonate. The aim was to bring bicarbonate level above normal, which was 22 or more. This was the patient population. No surprises here. It is a reflection of East London population. At that time, even then, almost commonest cause of kidney failure was diabetes, more males against females. And as the reflection of our population, almost 50% were ethnic minorities and 50% were white Caucasian population. The two groups are identical at baseline in their blood pressure control. I told you that uncontrolled blood pressure was an exclusion criteria. And I think that even at that time, I was running blood pressure which were, I think, most of us will be proud of in this ethnically diverse group of patients. They were very good blood pressure controls, and they had acidosis, which was mild, and they had the urinary sodium excretion, which we had was around 140, which would equate to around about 10 grams or so. And they were proteinuric at around about 1.7, 1.8 gram of proteinuria. So first results I'm going to show, it will be progression of renal failure. So the first thing I needed to show that by giving them sodium bicarbonate, I am improving their bicarbonate levels. And by that end of the study, they reached around about 24, which is very, very good for me. I was blinded, as well as the PhD student who was doing this work, which was a dietitian, believe it or not, who was doing this work. And she was my PhD student. She was blinded as well. So we were just looking at and the bicarbonate level in the bicarbonate group. So it means patients were taking the bicarbonate. The urinary sodium levels to just see whether it is increasing the urinary sodium levels, which I expect it would be in those who had taken sodium bicarbonate. And reassuringly, those people who were taking sodium bicarbonate, I was retrieving all the sodium which I was giving as part of sodium bicarbonate. I'll come back to that, which is very useful observation, that we were seeing that the level of sodium excretion increase was equivalent to the amount of sodium they were taking in millimoles orally as part of sodium bicarbonate. This strategy did not affect blood pressure. I didn't expect that would happen because sodium was coming out in the urine and there was no sodium overload. As a result, I was not expecting any difference in the blood pressure, and there was no blood pressure difference. It did not have any effect on protein excretion. I was not expecting that either, because acidosis would have very little effect on proteinuria. So all so far good. What happened to the creatinine clearances? You can imagine that what I showed in observational studies, that the rate of decline, those patients who were non-acidotic, they had a GFR decline of 1 mil per year. And that's what I converted these patients into. They became, by correcting their acidosis, the GFR decline became an age-related decline. However, those who did not get bicarbonate and remain acidotic, their GFR was declining at around about 3 mils, which I had shown in observational study. So basically, taking observational study, I was able to convert the rate of decline of GFR by giving them sodium bicarbonate to the level which we were seeing in non-acidotic patients. So very interesting, very useful. Obviously, GFR is GFR. How many patients ended up on dialysis? 33% of the patient in control arm end up to dialysis, as against only 6% of the patient in bicarbonate group. Again, very solid data, hard data, that it did prevent patient going on dialysis over a 2 years period. Whether there were any other collateral advantages of correcting acidosis, and that would be on nutrition, because there was enough data showing that acidosis causes protein catabolism and also promotes protein malnourishment. So we looked at that as well. So we saw that their anorexia disappeared and they started eating more protein. So the protein intake of patients who were on bicarbonate started to increase. Where this protein was going, obviously we wanted to see whether the protein which they're eating more, is it all being catabolized? To the contrary, bicarbonate inhibited protein catabolism, which was measured in that study. And you can see that by 12 months and 24 months, there was significant reduction in protein catabolic rate. So they're eating more protein. They are catabolizing protein less. So where is this protein going? And we looked at the albumin levels, which is a visceral protein, and you can see that the albumin level started to go up in parallel with the reduction in protein catabolic rate. More importantly, if you look at mid-arm muscle circumference, which is a parameter of muscle mass, that started to increase in parallel with the reduction in protein catabolism rate. The muscles become bigger, thicker, and also the power of the muscles increased. And this was sustained from 12 months onward. The most interesting thing which we all worry about is potassium. And as expected, with giving sodium bicarbonate, one would expect potassium to go down. And that's what we showed, that the potassium levels when we started was 5.6, 5.8. In bicarbonate group, it fell down to 5, statistically significant reduction in potassium, which was to be expected in somebody whose acidosis is corrected. So all things were going in the right direction. That correction of acidosis is not only preserving the kidney function, but it is also improving the nutritional status. And we will hear after my talk that nutritional status plays a huge role in the outcome of our patients when they are on dialysis or even in late stages of advanced kidney failure. We also looked at quality of life. We looked at physical health, mental health, kidney disease issues, and patient satisfaction. And all the parameters, whichever way you looked at it, that bicarbonate improved. So here the colors are reversed, sorry. The red ones are control and interventions are blue because it was a separate publication and a separate presentation. So I did not change the colors, but you have to say that the blue is the intervention group, which is bicarbonate. So physical health improved, mental health improved, kidney disease, quality of life disease score improved, as well as patient satisfaction improved. So it did slow the rate of progression of renal failure, delayed the development of dialysis requiring end-stage renal disease. It improved nutritional status. It was a better quality of life. And most importantly, it was safe, cheap, and well tolerated. Didn't require any new drug or whatever. Literally, you could buy it as a baking soda and start treating it. And that was the aim of the study, that this therapy should become applicable if it was good, even in the developing world, and they don't have to break their pockets to get benefit from this. That's why I did not patent this whole project. It was left to be unpatented so everybody can benefit it. There were publications, obviously, as a result, which you always like to see at the end of the day. There are many review articles written about the studies subsequently. All of them have been generally positive. Just coming back to this sodium load, which we were giving to these patients, and I was convinced that we will not show any fluid overload with sodium bicarbonate, based on this very interesting paper, which was published in 1975 in patients with GFR of less than 10, where they gave equivalent amount of sodium chloride and sodium bicarbonate to see whether sodium chloride or sodium bicarbonate is, are there any differences in sodium retention? And to tell you, to cut the story short, it was the sodium chloride which led to sodium retention. Sodium bicarbonate, most of the sodium which was given as a part of sodium bicarbonate was retrieved in the urine, even with GFR of 10. Remember, we did not include anyone with GFR of 10. So even with that advanced stage renal disease, this paper was telling me that it is safe. So that's why I was quite convinced that we will not cause any harm by giving them sodium bicarbonate, which was subsequently proven. But our American audience did not accept that. They had to say that they are not comfortable using sodium bicarbonate. So a company called Tricida, who got my advice about development of a resin-based chloride chelator in the stomach, which would then induce alkalosis in patients. A bit like pyloric stenosis, if you just vomit all your stomach contents out, you get alkalosis. It was based on that sort of a philosophy. These were the top scientists who also gave us Lokelma and Petiromere. They were onto this, and they developed a drug which is called Viveramere, and they done a randomized controlled trial and were able to demonstrate that over a period of 12 weeks, by giving Viveramere, not sodium bicarbonate, no sodium, they were able to increase the sodium bicarbonate level in the blood. So that was for the American audience, was published in Lancet. But it was 12-week study. We wanted to see the outcome study before this drug get licensed. If it would have been licensed, I can tell you that the cost of this drug would have been possibly quite high. like Lokelma, or at least in the same territory. Then a randomized controlled trial was done. It's not yet published. It was presented in late-breaking trial, which was I was privy to seeing the data. And this is the data, which is the very huge study, 741 patients in the Weber-Emmer arm and placebo arm, chronic kidney disease patients. And you can see that there was no difference in the outcomes, whichever way you look at it. And the reason was very clear, that after 3 months of increased sodium bicarbonate, the benefit of Weber-Emmer disappeared. And at the end of the study, the bicarbonate level in this huge study were the same. There was no separation of bicarbonate. So basically, even the placebo-treated patients were getting sodium bicarbonate from somewhere. Somebody was giving them, or the clinicians were giving them. And as a result, there was no difference in the outcome, because the moral of the story is that both groups got treated for their acidosis. Weber-Emmer versus placebo had identical bicarbonate at the end of the study. So that is the end of, believe it or not, that's the end of Tricida. Tricida have now stopped developing this, and Tricida has now been folded, finished, because this study didn't go in that way. When I advised them, I told them to try Weber-Emmer against a bicarbonate soda to see if there are equivalent benefit. If they'd done that, then clearly we would have had the same outcome, and that would have shown that Weber-Emmer can be used as an alternative to sodium bicarbonate. But here you go. That was the study which was designed by their company principals, and sadly, maybe a good drug which has now gone to the shelf and will never be used in clinical medicine. Acidosis and renal transplantation, few words about it. I've been interested in this for a long period of time, but from a different perspective. Again, a Switzerland group invited me to give them advice about how to conduct their study. I told them not to do it, but anyway, they went ahead and do it, and it will become clear why I told them not to do it. Whether there is evidence that acidosis does happen in transplant patients, yes, there is observational evidence that if you have got low sodium bicarbonate, those patients lose graft prematurely. Whether it is because the graft is defunct or is it because of the acidosis, the same observational study should apply, that if you've got acidosis and you're seeing graft loss, can you prevent that by correcting acidosis with sodium bicarbonate? And that was the basis of a Switzerland study, which they did and recently published in Lancet. Very, very nicely study. I would say better than my study, because they learned the lessons from my study, and they even use a placebo. And they also use an enteric release sodium bicarbonate tablets, which I think is now available in UK, called Nephrotense. They use this drug against a placebo, 122 patient in one arm, 120, very big study in patient with what you call acidosis post-renal transplant. This is the study population, which were almost similar, identical in all way you look at it. Clearly, because it's Switzerland, there are more white patients than ethnic minorities, which possibly would not be applicable to our group of patients, or at least East London group of patients. Apart from that, a very good study indeed. And these are the results. If you look at it, that the eGFR in the two groups, placebo, sodium bicarbonate, did not change at all over 2 years period. The sodium bicarbonate was separated, but if you look at it, that the sodium bicarbonate level were falling in the placebo arm, and the level which they managed to achieve after giving 3 grams of sodium bicarbonate was around about 22. I would have expected it to be 24, 25. I will come back to that in a short while, but that is where I think if there was any criticism of the study was that the bicarbonate levels were not pushed higher. Possibly that would have helped. They managed to look at pH as well, even though 7.36 and 7.38 would not be much different in a normal clinical setting. but they were able to show that there was minimal benefit when it comes to blood pH. And there was no effect on proteinuria, even though, as we all know, that the proteinuria levels in stable graft are pretty low as compared to native kidney, but still there was no difference. So the bottom line is that this study is regarded, one would say, as the neutral or negative study, and based on this data, one should not use sodium bicarbonate. But I would just like to say that, yes, good study. They did not show us the nutritional data. I would not expect that to be a major issue because most of the transplant patients are well nourished and possibly would not have any impact, but it would have been nice. And that was my advice to them, that if you do that, please look at the nutritional aspect and quality of life. That data possibly will come if they've not published it. But what is my take? Why did I advise them not to do the study and do another study? And that is the reason. I just would like to tell all the audience, I'm sorry, I'm just running a little bit over, that Gitelman syndrome, all of us know it's a very rare condition. And Gitelman disease is because of loss of function mutation in sodium chloride co-transporter in the distal tubular cells, which leads to what we will call hyperkalemia as a result of this disease. In transplant patient, you get Gordon syndrome, which is the mirror image of Gitelman's, which is the opposite of Gitelman's, because CNIs, which we use, cyclosporin and tacrolimus, upregulate sodium chloride channel. This remains phosphorylated. So it becomes like a gain of function mutation, which happens in Gordon syndrome. And these people get opposite to Gitelman's hyperkalemic acidosis. And I think those of you do transplant patients, you do see every now and then potassiums are a bit higher, and most of our patients do run a little bit of acidosis. The treatment of this acidosis is thiazide diuretic, which will give you double benefit. You'll get normal tension, which most of our CNI patients have got hypertension. And also it will correct the acidosis and potassium issues. So yes, acidosis, all acidosis are not the same. I think that CNI-induced acidosis in graft setting is due to gain of function of sodium chloride channels, and we need to give thiazide diuretic to treat that acidosis rather than, and that's what I advise them to do, thiazide diuretic versus placebo study in acidosis of transplant. But here you are, study is done and it was negative. But if any one of you in the audience are young, bright, upcoming investigators, if you really want to study what I've told you just now, it would be a study calling to be done, that acidosis in graft setting, one should give thiazide versus placebo and see if that has got a beneficial effect, which we could not demonstrate with exogenous supplementation of bicarbonate. And this is where I will stop and will be prepared to take questions, but I think question session would be after the second speaker. So thank you very much, and I apologize for going over. Despite me talking very, very quickly, I thought I'd help carry the message through. Thank you.
Thank you very much, Magdi. That was a brilliant talk and really interesting. So we'll do questions at the end, and I'm just going to hand over to Beverly now. So Beverly Bain-Cobb is a specialist renal dietitian with a research interest in acidosis. So I'll hand over to you, Beverly.
Thank you, Kunal. Right, let me just start the share. Okay, now I'm hoping that everybody can see that.
Yeah, we can.
Okay, right, and I'm just going to I'll switch my camera off there. Okay, right, so hi, as I've just been introduced, I'm Bev and I'm a renal dietitian from Coventry with an interest in chronic kidney disease, acidosis and hypertension. And today, my sort of role is to talk a little bit about the management of CKD acidosis from my perspective as a dietitian. I think sometimes in pre-dialysis care or conservative care. I think that sometimes acidosis can be a bit of a poor relation in the management of CKD, and there's a number of reasons for this. But before we talk about the sort of treatments and things in a bit more detail, I think I'd like to get you a bit more involved, and we've produced a short poll for you to complete about acidosis management in your trust. So in a moment, I'm going to stop sharing my screen and Diane will put up the poll for you to complete. And once that's completed, we'll return to the presentation and we'll discuss the results of the poll during the discussion session at the end of the presentation. So Diane, I'm just going to stop sharing for you to do the votes.
Can you see that, everyone? Hello?
Yeah, we can.
Yeah, okay. Right, yeah, I'll give you a few minutes to answer each question and I'll just take it down. That's question 1. Okay, question 2. Question 3.
Can you scroll down a bit? Oh no.
Question 4. Is everyone completed? Yeah. Now, are you happy that I end that yet? Or
Yeah.
do you want... Yeah, I'll end it and then I'll stop sharing.
Okay, now I'm back to sharing my screen. Can everybody see my screen again?
We can.
Okay, brilliant. Thanks. Okay. So, I mean, first of all, thank you, Magdi. That was like a brilliant introduction to clinical acidosis, and I only hope I can follow it really. One of the things that I wanted to, let me just get the slide up. One of the things that I wanted to highlight, but not spend too much time on, before we dive into treatment strategies for CKD acidosis, is the issue of subclinical acidosis. And I think that what's quite important to note is that when CKD patients present with overt clinical acidosis, so a serum bicarbonate of less than 22, for example, they have probably been subclinically acidotic for a while. Some patients may never present with clinical acidosis, but they may be subclinically acidotic. And that's important because behind the scenes, the process of producing sufficient bicarbonate to maintain acid-base balance is causing significant inflammatory damage, which is in some of the slides, obviously, that Magdi presented. And this is associated with negative outcomes. So consequently, clinically, the research race is definitely on to identify clinically useful biomarkers of subclinical acidosis to support early treatment. And I think that's particularly important because I think diet probably represents one of those early treatments. Okay. So from my perspective as a dietitian, how should we be treating CKD acidosis? There are a limited number of treatment options available, and they include sodium bicarbonate or citrate therapy and low acid diets. There was the more recent interest that Magdi's sort of presented about acid binders. And, you know, the recent results have actually not supported their use, you know, for the future. But for today, I'm actually just going to focus upon sodium bicarbonate therapy and low acid diets and my experience of those. If you look at the evidence for sort of acidosis as a driver of CKD progression, I think Magdi presented some very convincing evidence of that. But what is the evidence that an intervention in the form of sodium bicarbonate actually works? Hierarchically, systematic reviews and meta-analysis do sit at the top of the research tree. And more recently, there have been 3 reviews spanning about 14 trials and I think 2,500 patients, which have evaluated the impact of sodium bicarbonate on CKD progression. The evidence does actually support the use of sodium bicarbonate to delay disease progression. However, some of the grade analysis of the systematic review of the meta-analysis highlights that there's very uncertainty in the results, with most of the outcomes actually coded as sort of low certainty, or at best moderate certainty. And I think it's important to understand why this happens when we're looking at some of the systematic reviews. And I think it relates to the fact that there's a huge amount of heterogeneity in the trials that have been included in these systematic reviews. There's differences in the dose of sodium bicarbonate prescribed, the duration of intervention, serum bicarbonate levels at baseline, if acidotic patients were indeed included in the trial. So that heterogeneity, I think, actually impacts on the certainty of the outcomes that have been seen in these systematic reviews, even though it does suggest that sodium bicarbonate is indeed an appropriate treatment for this patient groups. So consequently, what I would just like to do is actually look at a few more of the larger randomized controlled trials that have been included in all of these systematic reviews, and to sort of put it into context. And I think one of them, actually, one of the trials I'm about to show you is Magdi's trial that he showed you, that was conducted at the Royal London. But 4 of the biggest trials that were included in these meta-analyses, of them, 3 of the trials demonstrated positive outcomes. And there's a few things that will be interesting to sort of pick up here. The Gorea trial, which is the 2021 trial, they are publishing 3- and 5-year data for this patient cohort, which compares sodium bicarbonate, low acid diets, and usual care. And what's interesting, in terms of kidney disease progression, the low acid diet and the sodium bicarbonate group are performing equally well, which is really, really good to know in terms of clinical practice. But the low acid diet is actually starting to pull away from the sodium bicarbonate arm in other areas. So other cardiovascular risk factors, things like pill burden, blood pressure, and body mass index. But that's not saying that the sodium bicarbonate isn't working. It's just that the diet actually has some additional benefits that it can provide. In terms of the trial that didn't show any sort of positive outcomes using sodium bicarbonate therapy, that would be the Withermitol trial, and that's the bicarb study that was conducted here in the UK. And that was a study that looked at using sodium bicarbonate in individuals who are over 60 years old. And the trial group reports that it was possibly the dose of sodium bicarbonate used that was perhaps too low to produce any meaningful change. And I think this is really, really interesting, because when you actually look at how much per kilo these patients were getting in this trial, it was probably about 0.3 milliequimoles per kilo, whereas in Magdi's trial in 2009, the patients are actually on average getting 0.2 milliequimoles per kilo, and there were some real positive results that were shown with that. So I think it's a little bit more difficult to interpret, but I think the evidence is there that supports the use of sodium bicarbonate. So I think it leads us on to the next sort of question is, how and when should we be using sodium bicarbonate? When do we treat? What dose do we use? And what are we aiming for? Guidance regarding the use of sodium bicarbonate in clinical practice is, in my opinion, a little bit vague and a little bit variable. In the UK, NICE guidance states that the management of acidosis is beyond the scope of the guideline, but they then go on to say that only CKD 4 and 5 individuals with a serum bicarbonate of less than 20 should receive treatment. I personally don't think this reflects the evidence. And some of our patients will be acidotic before they reach stage 4. And I think it's excluding a big group of patients, and actually patients that could then go on to progress their kidney disease much faster than they otherwise would have if they're left untreated. Furthermore, Renal Association and KDIGO guidance suggests that bicarbonate values of less than 22 or lower than your normal hospital range should be treated in any stage of CKD. And I think that probably does sort of reflect the evidence, but there is no guidance available regarding what starting doses you use, any titration, and anything to support clinical practice. One thing that KDIGO does, and that's the KDIGO CKD guideline from 2012, one thing it does do is highlight the controversy regarding sodium loading and blood pressure when using sodium bicarbonate. Now, we've just heard that Magdi presented some papers from the 70s that showed that sodium in the form of sodium bicarbonate equals sodium out, basically, and that certainly was supported by his trial. But there seems to still be this concern in the sort of nephrology community using sodium bicarbonate and its potential impact upon blood pressure. And I suspect those concerns really exist because of crossover from sodium chloride from salt trials and blood pressure trials there. So we don't really have great guidance to tell us how much sodium bicarbonate to use, but there is, I could guess, some guidance to suggest when we should use it, and that's probably when our patients have a serum bicarbonate of less than 22. So with all this, if there's no guidance for clinical practice, how do actually the trials determine sodium bicarbonate dosage? Interestingly, the trials using sodium bicarbonate show quite a lot of variation. In my group's recent paper, which evaluated the impact of sodium bicarbonate upon sodium blood pressure in CKD, we found that the median dose used for sodium carbonate was 0.5 milliaquamoles per kilo, but the range was actually 0.2 to 1.2. So the range is actually quite significant. So practice really did vary from the trials. Just to give you a sort of an oversight of what 0.5 milliaquamoles look like, it probably translates to about 3 grams of sodium bicarbonate a day. Most trials declared a dose per kilo or even per kilo of lean body weight, but some trials also made a dose adjustment for the serum bicarbonate level. So the lower your serum bicarbonate, the more sodium bicarbonate the participants were given, but there was actually no standardized approach, and there doesn't seem to be a standardized approach to sodium bicarbonate dosing across the literature. The other thing that I think varies, one thing to say there as well is that the BNF actually states that in acidotic CKD patients, the target dose is 4.8 grams daily. And I was really fortunate enough to be to speak at the Renal Pharmacy Group conference in September, and there aren't many renal pharmacists who are able to understand where that figure came from, and it's not really referenced in the BNF. So I think that's quite an interesting statement there. In terms of targets, again, targets really do vary, and this often relates to the type of participant included in the trials, because not all trials included subjects who are clinically acidotic. In fact, in my experience, in our review, only 50% of the trials contained participants who had a serum bicarbonate of less than 22. We know that from the data for serum bicarbonate, it does have that U-shaped curve, and that serum levels should be monitored fairly closely for individuals on treatment, but we actually don't know really where those levels are at and what we should be aiming for at the higher level. I think it's probably safe to say that as ever in clinical practice, we need more information, and that would be really, really nice. In search of more information and in search of understanding our practice a little bit more, we conducted an audit of the management of CKD metabolic acidosis at our local trust in Coventry. NICE guidance actually states that the treatment of acidosis beyond the scope of the CKD guideline and to refer to local units for advice. So we don't actually have local guidance advice. So we weren't auditing against Myria's standardized criteria of local guidance. We were more trying to establish our baselines to understand our practice and where and how we can improve. And over the next few slides, I'd like to share the highlights of this audit with you, because there's really not enough time to go into the depths of the audit. So it's really just the headlines. So our audit was conducted between June 2020 and June 2021. And it was a retrospective audit of CKD 4 and 5 non-dialysis patients. We used a data download from Proton, which, you know, in itself, Proton data, it has its inherent problems, and it's only good as the data that's put in, and is subject to quite a few errors. And I also produced a 2-minute, I had timed it to make sure it was only 2 minutes to try and encourage participation, a 2-minute survey monkey that I sent out to the MDT. I haven't noted it on the slides, but the response rate to the survey monkey was approximately 60%. And serum bicarbonate treatment targets were 22 to 29 millimoles per litre, which at the time represented the range previously at our trust. Okay, so what did we find? To be honest, we were quite shocked and disappointed at our results. And we know that we've got a lot of work to do to improve our practice. And I suspect, although can't say for sure, that we're not isolated in our approach to acidosis management at a unit. And, you know, yeah, that we're not. The sample size in the first download from Proton was actually pretty big at 1487. However, our first shock came at data cleaning when we lost almost half our sample because they didn't have a serum bicarbonate measured within the audit period. Now, for some, they didn't have any bloods at all, but for most of the patients, it was they didn't have a single serum bicarbonate measured in that period of 12 months. I should point out that this was COVID time, so our patients were less likely to get blood results checked in that period, but I think that we felt disappointed in our results that half of our population had to exit because we hadn't measured something. But for those who had a serum bicarbonate measured, 30% of them were acidotic, and only 25% of those who were acidotic were actually on sodium bicarbonate. So it kind of shows that we're actually not doing a great job at identifying and then treating those who are on sodium, who are acidotic. Furthermore, where sodium bicarbonate was used, almost half of our patients were undertreated, so they remained acidotic. So we weren't doing a great job of identifying our patients. We weren't doing a great job of treating our patients. And then when we did treat our patients, we didn't do a great job of getting up to target. And I suspect that I'm not really sure if it was if this was about our dosing practice, our practice, or patient concordance. I suspect it was a combination of both, but I think that there is definitely room to do better. In terms of the findings of clinical practice from the Survey Monkey, the majority of the team was quoting either NICE or KDIGO guidance for treatment targets, which was great because we were lining up with the literature, and this was very, very, very positive. And starting doses for sodium bicarbonate varied, but 50% of clinicians were starting at a dose of 500 milligrams BD, which to me, with sodium bicarbonate being my research area, I'd actually suggest that's at quite a low dose. But this was consistent with the data that we got back, the prescription data that we got back from Proton. So clinicians were definitely reporting the same as what they were doing. So that was absolutely great. However, there was real variation in the doses prescribed, and overall the team was pretty cautious with sodium bicarbonate prescription, citing concerns regarding blood pressure and antihypertensive use and edema or diuretics as being the major determinants of starting or not starting sodium bicarbonate therapy. And I think that's something that's really quite important to unpick, and I think we can probably hopefully do this throughout this presentation, and I think Magdi's already done a pretty good job of that already, but there's some work definitely to do on that, certainly at our trust. And what was very interesting is 68% of clinicians did not prescribe doses of sodium bicarbonate which were more than 4 grams. Now that is consistent with the research literature, but I actually think there's definitely room that we could go up beyond 4 grams to manage acidosis in our patient group. So in terms of our audit outcomes at our trust, I think this is a bit of an eye-opening audit, and the outcome of which is that we will be producing locally auditable guidance for the management of acidosis. And as part of my research, I'm evaluating the evidence regarding sodium bicarbonate therapy and hypertension. And I'm looking at education sessions for our team and hopefully beyond that, to sort of, I hope, reassure people that sodium bicarbonate is not a disaster in terms of blood pressure, and actually maybe we can support its use, but it's really cheap. an effective drug for our patient population. So, question, is sodium bicarbonate a promoter of hypertension? So I think that Magdi's already said this, and I personally also don't think that there is any evidence to suggest that sodium bicarbonate promotes hypertension. Our current systematic review and meta-analysis, which was released ahead of publication 2 weeks ago in Sedation, actually looked at blood pressure change in studies where sodium bicarbonate therapy was used in CKD, but it also evaluated antihypertensive drug changes and diuretic drug changes as a surrogate for blood pressure change. And our results suggest that with moderate certainty, blood pressure isn't negatively influenced by sodium bicarbonate therapy. Moreover, there is a suggestion that some antihypertensive drugs may actually reduce in those patients who are on sodium bicarbonate therapy. I think that in support of what Magdi was saying, really, there is long-standing evidence from Husted in the 70s, as we've already seen, and Luft in the early 90s, to suggest that all sodium salts are not equal in their impact upon blood pressure. And sodium in the form of bicarbonate is excreted, whereas sodium in the form of chloride is not, and hence its limited effect on fluid and blood pressure. And I think we really do need to be careful not to transpose sort of particularly observational and intervention data from SALT, as in sodium chloride studies, to this patient group. So now I've introduced a bit of controversy. I think I'll move on to the area where I'm pretty secure, which is probably diet. There is a growing body of literature that demonstrates that a higher dietary acid load is associated with the risk of and progression of CKD. So the more dietary acid you consume, the more likely you are to develop CKD, and the more aggressively your CKD will progress. But on the flip side to that, a low acid diet has also been shown to improve CKD outcomes and improve a number of outcomes in CKD, not just progression of CKD, but some of the nutritional status that Magdi alluded to earlier, bone health, and a number of other things. So what is dietary acid? Generally, diets with a high content of animal protein or refined grains or processed food and salt are high in acid because they contain a lot of metabolic acid, which generates hydrogen ions. And very often these Western diets, these sort of very high animal protein or processed food diets, also have a low fruit and vegetable content, which compounds the issue because fruit and vegetables contain base producing agents such as citrate or malate that actually generates bicarbonate. So with that theory, if you had a lot of acid in your diet from animal protein, as long as you ate enough fruit and vegetables to actually produce enough base, with that theory, you could actually produce neutrality. But the average Western diet and the average UK British diet does not have much fruit and vegetable content, and it's probably got a lot of processed junk as well. And ultimately, to maintain acid-base balance, we need to excrete the same amount of acid as the amount that we produce. And this doesn't really happen in Western diets. And as a consequence, we need to produce more bicarbonate via ammoniogenesis, which causes inflammation and causes the impact on kidney disease. But the good news actually is that we can actually reduce our acid load by changing what we eat. So how do we quantify dietary acid load in clinical practice? Quantifying dietary acid load is possible using urine studies and or equations that calculate the renal acid or base forming potential of a food item. Now, you can use these equations to determine how much acid or alkali a patient has eaten overall, or you can actually make a big list of foods and say these are high acid, these are alkaline foods, and you can sort of manage a low acid diet that way. Using equations to generate potential acid values from foods it's actually quite tricky in clinical practice, and I think it's probably something that's going to be a challenge in clinical practice, and it's probably a more clinically useful research tool. We do have some acid load, some potential renal acid load databases where there's lists and lists of food and how much acid or alkali they contain. And clinically, some of the dietitians in the US are actually using these databases and using these massive food lists, so patients can actually monitor everything that they eat, and they can actually decide whether they get to this 0 balance that they're aiming for each day. Now, I actually think in clinical practice, monitoring and managing renal acid load that way is fraught with challenge, and it's really, really unrealistic. I mean, what are we doing to our patients trying to get them to engage in that? They've got to be incredibly motivated, incredibly able, and I, as a dietitian, am not sure I could keep that one up. So while some renal dietitians in the US are having some success with such interventions, I think you'd be glad to know that there are some alternative routes to actually reducing acid load in diets that we could use instead. Dietary patterns such as the Mediterranean and DAS diets are actually low in acid if they're managed well. And moreover, Wesson's group in the study that I mentioned previously that had 3 arms, and it was a sodium bicarbonate arm, the low acid diet arm, and the control arm. The way that they've actually managed to lower dietary acid load is that they had charity funding for fruit and vegetables for participants and members of their households in the study. And what they did is that they calculated an amount of fruit and vegetables equal to 50% of the participants' calculated dietary acid load. And they then also cancelled with reducing salt intake and reducing animal protein and reducing processed foods. And their outcomes absolutely fantastic. And I think it just shows that it doesn't have to be a really difficult, a really complicated dietary model, but actually you can achieve some really great outcomes with some fairly simple interventions. So when should you start a low acid diet? I honestly believe that clinically, acidotic CKD individuals, all of them should be seen by a specialist renal dietitian. And I think, as with phosphate binders, I think dietitians are actually ideally placed to manage acidosis because they're able to evaluate the acid load and actually provide some sort of understanding of whether the acid load can be reduced by diet, or if there's a need for sodium bicarbonate, or if there's a need for both therapies. But actually, it would be a really good area that I think the renal dietitians could go on to manage. But then I think we also need to start to think about the subclinical acidosis patients, and perhaps all CKD patients that enter our unit programs or enter our clinics should at some level be educated on a low acid diet. Correa's group is actually, which is actually Wesson's group, but are actually showing really good outcomes for other cardiovascular risks. So is this something that we should be doing? And is it realistic in our current clinical setting? Now, I think I'd be a little bit remiss if I didn't acknowledge the potassium elephant in the room when talking about low acid diets. And I think that increasing plants, increasing fruit and vegetable is probably something that concerns the renal MDT. However, I think we should be mindful about a few things. Potassium from animal protein sources has a really high bioavailability, so we'll absorb it and we'll absorb most of it. Whereas potassium from plant sources has a really low bioavailability because it's released so far down in the gut, usually by our gut microbes. So we don't actually absorb all of the potassium from plant sources. But when you analyze both in a test tube, you will get the same potassium result, because test tube analysis, which produces food tables, is very different to our digestion. There's also no evidence that low potassium diets work. And moreover, more recently, there is increasing evidence that low potassium diets are associated with increased CKD and increased CBD risk. So that's definitely something to think about, to take forward. And I think for me, puts together the whole of the picture that actually low acid diets are possibly the way forward. And actually, you know, low potassium diets and the way we currently construct them should be a thing of the past. So I'm just mindful of the time. So to conclude, I really believe that sodium bicarbonate is an underutilized and simple treatment strategy for CKD metabolic acidosis. And I actually think the concerns regarding the use of sodium bicarbonate, mainly related to hypertension and edema, I think they're completely unsubstantiated in the literature. I believe that dietitians are actually central to the management of CKD metabolic acidosis, particularly if we become supplementary prescribers. And I think that whilst locally we're producing detailed auditable guidance for the management of CKD acidosis, I think it would be much easier if we had one set of guidance that was done at a national level, so we didn't all have to reinvent the wheel, particularly at times of such crisis in the NHS. But as ever, more research is needed to support the use of sodium bicarbonate in clinical practice. Thank you very much for listening.
Thank you, Beverly. That was a really brilliant talk. And I think Suzanne's going to take over the questions.
Thank you. Thanks to both of you. I think two very different talks, Magdi giving us a tour de force of the history of nephrology and acidosis, as I would expect nothing less. And then Beverly with a much more kind of, I guess, perhaps practical approach for us all to think about. And just looking at the list of people in attendance, it's great to see this is really a properly MDT attended webinar with certainly a couple of dietitians that I know logged on, and I'm sure many others as well. Perhaps the best place to start is with the poll, which is flashed up in front of us. Beverly, I don't know if you want to talk to this or run.
Yeah. So I'm quite excited about this poll. Yay! That's really great, actually.
I'm amazed it worked. That's fantastic to even start with.
Yeah, Diane. Big snaps to Diane, I think. So I'm actually so pleasantly surprised that 38% of respondents have local guidance. So that leads me to my next question. Can we have it, please? Can we borrow it? Because actually, or can we use it as a basis for something at a national level? I mean, I can't quite say how many units there are in the UK, but I think we could all benefit from that. And that's really good. And that's really positive and really, really great to see. And despite Magdi's best efforts and my best efforts, and hopefully that the paper that was published ahead of print in Sedation will really hopefully start to put this thing to bed. But, you know, look, there's still a quarter of people that are still really worried about using sodium bicarbonate because of blood pressure. I just think that, you know, read the papers, read it coming out. It may help to reassure you, but I really don't think that it's the big problem that it's seen to be. But I'm more, I guess that I am more reassured by the fact that 31% of people aren't worried about blood pressure. So there's definitely a change, and there's definitely something positive there. And with the 44%, I hopefully that we've changed your mind today, and that you'll be more confident in using sodium bicarbonate and not worried about its impact on blood pressure. I suspected that not many people would refer to dietitians for acidosis, probably because it's not on referral guidance. But also, I'm not sure how many dietitians would actually go out and actually get patients for management of acidosis. And I think that's borne out with what the dietitians have to say as well, in that they really aren't confident there's enough guidance on how they treat this. So I think that's a really big area to work on, you know, referral practice and how do we do it, because it's infinitely doable. So I think that poll was great. And I hope that at some level, we've helped today to grow practice there.
Yeah, no, I have absolutely no doubt that will set some thoughts and motions, and certainly Magdi will shout me down if I'm wrong, but I don't think we've got any clear guidance in our trust, and I've really enjoyed actually working more closely with my dietetic friend, who is on the call in our transplant low clearance clinic, although then you've kind of made me question if that's the right thing to do with the failing transplants with some of the papers that we've looked at. I'm having a look on the chat and the Q&A, and I can't see any questions from the audience yet. So if you do have any questions, do pop them on. We've got a couple of more minutes that we could look at those. Natalie's popped her hand up, which is very helpful. And then I've got one of my own as well, which I'll pop in with afterwards. Natalie.
Yeah, thank you to both our speakers. That was really, really interesting. And I guess I'll put the question to both of you, but perhaps Beverly, you could start. Obviously, over the years, the trend of low protein diets has been in trend, out of trend, and back in again with slowing the progression of CKD. And listening to your talks, I wonder how much you think that that is actually the low acidosis of the diet as opposed to the low protein diet that's having that overall impact.
Yeah, I think that's a great question. I think the move is towards dietary patterns, and I would say a low acid diet is about a dietary pattern, because with a low protein diet, you are taking acid out, but you're not necessarily putting any base back in, because I think that the traditional low protein diets are probably lots of bread and pasta, which actually isn't going to do anything for your bicarbonate generation. And I think that what we're trying to do now is actually show that balance. I think one of the things that really interests me, and I'm not sure if Maggie could comment as well, is that you could probably eat quite a lot of meat as long as you had quite a lot of animal protein and acid, as long as you had enough base. And that's certainly something that I was listening to on a webinar quite recently. But that's not something I'd be that comfortable doing as a dietitian, for sure. So yes, the low protein diets were probably to an effect becoming low acid, but they probably weren't getting to the levels of low acid intake that you'd find if you start actually upping fruit and vegetables. Does that answer part of the question?
Yeah, thank you. And I'm just interested for other speaker to comment as well, if you don't mind.
I think, first of all, Beverly, great job. So refreshing to have, because as I said, that when I did this work, the PhD student who worked with me was Yoni, and she did the PhD on not only sodium bicarbonate, but sodium chloride. So I have huge respect for our dietetic colleagues. So that goes without saying. So thank you very much for your very nice presentation. Just a question about low protein diet. When I did, as a medical student, that journal club, at the request of my professor in front of some seriously top nephrologists of the time, I had said that at that time, that maybe low protein means low acid load, and that would be reflected in low phosphate. If you cut the protein down, you reduce phosphate. If you reduce protein, you reduce sulfate intake. Both sulfate and phosphate go into the body and form weak acids. So that goes without saying that acid load is high in animal-based proteins more than when it is plant-based protein. Plant-based protein was in disrepute because of the potassium issues. How wrong we were, that potassium is from the diet is the cause of hyperkalemia in many of our patients we see. And sadly, that is not the case. I've known this for 25 years. I never stop my patients eating fruits or bananas even, because the bioavailability of potassium of these starch-rich products is negligible. So just for the audience, just to reassure you, and we have done this work, that for every 10 millimole of potassium intake you take extra, it equates to 0.2 millimole of potassium change in your plasma. So I'll just say that if you were to have 50 millimole of plant-based potassium, it will equate to 1 millimole of potassium increase in your blood. So if you're starting with 5, it will become 5.1. And we all know that our CKD patients can quite easily tolerate that level of potassium. And high potassium is now coming, believe it or not. There is a trial happening in Netherlands as we speak, randomized controlled trial, where they're giving potassium chloride, believe it or not, to increase potassium levels and see whether that has got any beneficial effect by lowering blood pressure. And some of the beneficial effects which we see of low salt is the effect of the high potassium. And I think salt substitution study in China has shown beyond any shadow of the doubt that if you were to even reduce 25% of your sodium and replace it with potassium-based salts, it reduced the stroke incidence. By the way, that is the first study in the world where they looked at stroke prevention as a primary endpoint. All the strokes are hidden in MACE, but this was the study designed to see if they could reduce the incidence of stroke. And by just doing that simple intervention at a population level, they were able to show. So potassium, I don't think so, is a poison as we were made to believe, or still many of my nephrologists believe, and sadly, Beverly, that is the combinant referral to the dietitian about, can you advise him to cut the potassium down? I sadly say that that should be replaced by something else rather than potassium. Potassium is not a major, dietary potassium is not a major contributor. I alluded to earlier, I'm in Roberto Zatz and so happens Tom Hofstetter. They're both my friends now. And I did say in my talk that ACE inhibitors cause hyperkalemia. So it is the drug-induced, which can be spironolactones, it could be ACE inhibitors. These are more culprit in causing hyperkalemia rather than a plant-based potassium intake. There is no comparison. There is no comparison whatever. And other thing I would like my trainees to ask them is that how much potassium is in the paracetamol tablet. We, without a blink of the eye, tell our patient if they get a pain, no, paracetamol is pretty safe. Just look at the covering of paracetamol and see how much potassium is in that bloody potassium paracetamol, which we give up to 8 grams a day. So please, wake up. Third thing is, just want to give you some very, very sobering data. I have been asked to write a review about the processed food, which you alluded to, Beverly. The global pharmaceutical market, which is the global total pharmaceutical use in the world, is $1.4 trillion. This is how much we spend on the drugs. Guess how much we spend as a globally on processed food? $4.4 trillion. How much we eat as a global level use this fast food, by which I'd say KFCs and the McDonald's of this world? $1 trillion. They are the one which are causing harm. If you were to take one can of Coke, that gives you 1/2 of your phosphate intake. We need to wake up to this, what is happening around us. And I think we need to advise our patient accordingly that fresh food, particularly vegetables, like Mediterranean diets, is pretty safe in our patients. So I would fully support you, Beverly, that this is where the misconception lies. And that is because of all the things which we have been practicing and not keeping an eye on the modern literature, which we should be, and learning from that and changing our practice.
Thank you. Magdi, I think that's a potential other 3 talks in the making there. You're going to have to come back and talk to us some more. I'm aware that we're at 5:30, which is when we're meant to wrap up. There were a couple of questions on the chat. One is, I guess, to Beverly, just asking whether is there any national guidance being worked on to support us providing more advice to patients, or is that a long way off?
I'm really sorry, I haven't been at work for a little while, so I don't know. But it was something that was a topic of an RNG sort of afternoon in September, I think. So it's definitely something that's being talked about.
Watch this space.
Yeah, and plant-based is really taking off. So yes, hopefully.
Excellent. And then there's one to Magdi. Magdi, I'm going to challenge you to answer this in 20 seconds. So the question is, are there special patient groups that are prone to acidosis and would preferentially benefit?
I think anyone, first of all, I would even challenge the person who has asked this question, that there is acidosis. We have not talked about acidemia. Acidemia is when the buffer presence in the plasma is much lower, and when you eat postprandial, you get acidosis for a short period of time. Even that is dangerous, and has been shown by Dan Wesson from Dallas, that even at that early stage, when the GFR is 55 and 60, that consumption of buffer in your urine, which can be then demonstrated by urinary ammonia excretion, which we don't look at. So I would say that acidemia, we should be acting rather than acidosis. Acidosis, when the train has left the station, we should be acting much earlier and advising our patients to cut down acid load at that stage. One final point I would like to make, which is for Beverly, when you write these guidelines, I would be very happy to be involved if anything comes from our side, is phosphate binders. When we use phosphate binder, which is the common phosphate binders which we are using, very rarely we use them in our pre-dialysis patient, but increasing use is happening. The calcium carbonate is sodium bicarbonate. When we use calcium acetate, acetate gets converted into bicarbonate. If we give calcium citrate, citrate converts into bicarbonate. If we use lanthanum carbonate, that is carbonate. And if you give even Renal, that is bicarbonate. So we need to already look at that when we are looking at these phosphate binders, they are already partly correcting acidosis in our patients. And that's why sodium bicarbonate level may not be that 3 grams or 4 grams needed if you have also looked at the phosphate side of the thing, which sadly in preclinical, pre-dialysis population is completely ignored. Again, there is no guideline on it, no clinical trials done on this forum. So I would just say that we should also look at the phosphate binders, which also gives you enough bicarbonate to avoid sodium bicarbonate altogether. So I'll just stop it at there, Suzanne. And I think we'll be happy to talk again if ever invited. Thank you.
I think Magda, you just, sorry, can I just say, I think Magda, you've positioned dietitians for a bit more work. so yeah.
Brilliant. Well, I think we'll end it there, and just again to say thank you very much to both of you for such excellent talks and for joining us this evening for one of the highest attended webinars to date, I believe, which is fabulous. So thank you so much for your knowledge and for challenging us to change and think about things going forward. There's slides posted just to remind everybody about the dialysis conference, which is coming up in September. And then I don't know, Natalie, have we got another slide about there we go, the next webinar. So the webinars continue, and do feel free to spread the news and invite all the members of your MDT to come along. So the next one is in May, and it's talking about shared decision making, which is a topic close to many of our hearts in our dialysis patients. So on that note, we will wrap up and thank our speakers again tonight, and thanks everyone for joining.
Thank you very much. Thank you.
Thank you all.
Thank you so much.
Thank you.
Bye now. Thanks a lot, everybody.